let's go for the external features of the
Let's see
heart.
what we remember
Okay.
later.
So let's start with the base of the heart. The base of the heart is this portion, and that is the apex. And we have great vessels at the base. Okay. This one is what?
Pulmonary trunk.
Pulmonary tract, and this one is, and this one is, and this one is inferior vena cava. Now, the heart has coverings. Okay. The one that is directly adherent to the surface is called what?
Visceral pericardium.
Visceral pericardium. And the one that is outside
Parietal.
is parietal. In between the two is
Pericardial space.
pericardial space or pericardial cavity. Okay. And it has, who is that? Okay. And there is a minimum amount of fluids, about 15 to 30. We call that what? Pericardial fluid. And on the anterior surface of the heart, you have coronary vessels. Okay, let's start with coronary arteries. The coronary arteries originates where?
The aorta.
Aorta. Okay. So from the root of aorta, there is called bulb, okay, or sinus or valsalva, we call it, okay, and it gives big two branches, one is towards the left, one is towards the right, and the one that is going to the right is called right coronary artery. Right coronary arteries have many branches. The one that goes up like that is the right atrial branch, and there is another one called what? Right marginal, and then it goes back to the posterior portion of the heart and descends downward. Okay, and that is posterior descending. If you want to use Saladin, it's called posterior interventricular. Okay, that is the normal connection or supply of blood. Sometimes this posterior descending comes from the left, and therefore we call it left dominance, okay, because the left coronary artery is dominating. See, big chunk of the heart is supplied with the left. Okay, now, the one that goes to the left is called left coronary. From here to here, before it branches into two, is called left main. Why is it important to remember that? Because sometimes the obstruction is in that area, and the cardiologist, when you hear, it's in the left main. Okay. So
the left main, you said
from the origin here,
okay.
before it bifurcates.
Okay.
So an occlusion in the left main is bigger than an occlusion in the circumflex or the anterior descending, right? Because it
It's not-
occludes both of them,
The,
right?
the correct word is not bigger, but more significant.
More significant.
Yes, because when you have total occlusion in the left main, there is nothing more anymore. Okay, so that's why when you want to do percutaneous angioplasty, it's dangerous in there. Why? Because when you're doing dilatation, you occlude the blood vessel. So basically, there is no supply to the whole thing. Although it's time, you know, let's say 30 seconds, and then you release right away so that the blood will flow again. Okay. All right. So the first branch going down is called LAD, or left anterior descending, according to Latin. Okay. And then it goes around and what we call circumflex. Okay. Now there are several marginal branches. Okay. This one I think is the one is acute, one is obtuse. This one I think is the acute, and this one is the obtuse. Now, it is very important that you know the arteries, because later when you go to clinic, if the myocardial infarction is here, based on EKG, you should be able to identify what blood vessel. Okay? Why? Because at least when you send the patient to cardiac cath lab, they know already that's the blood vessel. Okay.
I have a question. I can't remember what vessel it is, but some cardiologists don't recognize it as a STEMI. I can't remember which vessel it was, but it's very controversial. I don't know if you heard about it.
Yeah, there is what we call STEMI and non-STEMI. Yeah.
But like on EKG, like there's an ST elevation and a certain lead, and a lot of cardiologists like will refuse to take the patient. I mean, eventually they'll take them, but they fight. I don't know which one.
I don't know either.
I'll find out.
Okay. Do you have any questions so far? How about the veins? The veins, basically what? This area of the vein is what?
Coronary sinus.
Coronary sinus, and which is continuous with the grade, exactly. And how about the other side? Small, exactly. And how about this one?
Middle.
The middle. Now, you will note that the anterior goes to the great and then coronary sinus. Where is the coronary sinus drains the blood? Right atrium, exactly.
So this is the grade, and then that's the coronary sinus.
That's the coronary sinus,
Right.
which is the terminal portion of the grade.
Okay.
See?
Oh, got it.
Yeah.
You have the grade and the coronary sinus.
If you have occlusion of the great cardiac vein, would you have myocardial infarction?
No, just have a build.
The opposite.
Because when we say myocardial infarction, it's usually involving the arteries. And not only that, well, eventually, yeah, collaterals will take care of it. Lymphatic system will take care of it. But if the big one is really occluded, that's a problem also. But usually it's not a problem, not a common clinical problem. Okay. So, any questions so far? Now, you have two blood vessels here going to the left atrium, and this is right atrium. What are these? The one on the top is
The left.
superior, left superior, and the other one is left inferior. This is right superior. And how about this? What is this?
Yeah, that's a pulmonary artery.
Pulmonary artery. This is the right and this is the left. Okay, then let's go. But before we go there, this portion of the left atrium is called appendage. This portion is appendage. Why is it significant clinically?
That's where the clots form.
Exactly. When you have atrial fibrillation, usually this is where the clots are formed. This portion is very hard to see in echocardiogram. So what do? We do transesophageal. Remember the esophagus is here. So when you put the probe here, very close, you can see clearly. Okay? That's why we do transesophageal if we are suspecting a clot. You learn later in patients that are prone to clot formation, there is a certain guide. If the patient has atrial fibrillation that is new onset and hemodynamically unstable, has to be cardioverted. The problem is, does the patient have clot or not? Because if you cardiovert the patient with a clot in it, you dislodge it. And this is the left atrium, it goes to where?
Go to your
Left ventricle. From the left ventricle, it goes to aorta. From aorta, it goes to
brain.
stroke. Okay, so you have to be careful. That's why most doctors, cardiologists, when they have atrial fibrillation, hemodynamic, sometimes they will insist on treating it conservatively, no cardioversion, because if it happens to have clot and you cause stroke, malpractice. Okay.
So, but that's only for new onset.
For new onset, hemodynamically stable, usually within 12 to 24 hours.